Well, Jorge, I've been driving the discussion with all these questions. I'm going to give you an opportunity to kind of wrap it up with what you think are a few of the outstanding questions or challenges that remain in the management of chronic phase CML.
Well, one of the important questions is, we've been talking a lot about arterial-occlusive events. I don't think we've done a good job understanding why. And the more we understand the why, the better we'll be able to prevent it, to manage it. And of course, it can help us with the better use of these drugs because they're good. We've been talking about how good ponatinib is, but we are concerned about these adverse events. We need to do that better. One important thing is we talked about the treatment-free remission, the treatment discontinuation. That's becoming increasingly a goal of therapy. But the reality is that it's effective. It works in only about 25% of the patients. Only about 25%, only about 50% of patients get to these sustained deep molecular responses. And of those, only about half of them remain free of therapy. So really only 25% can stop the therapy without a relapse. Now that's great compared to what we thought some years ago, but the majority can't. So we're trying to see how can we increase the number of patients that have a sustained deep molecular response, and how can we reduce the risk of relapse. We know TKIs alone cannot eradicate the stem cell. That's preclinical work. So there's a lot of work going into what combinations can we use. There's been some work with interferon. In Europe, there's been several studies combining different TKIs with interferon. There is very nice preclinical work with venetoclax. So there's studies that are starting to incorporate that and see if that can help you with that. There has been there's this new tyrosine kinase inhibitor called asciminib, very effective in the salvage setting. There's an ongoing randomized study against bosutinib in third-line therapy to see if it can gain approval in that context. But it also binds in a different place. It's an allosteric inhibitor of BCR-ABL. So there's good data preclinical that it synergizes with the different TKIs and it prevents the emergence of resistant clones. So there's also a study looking at that combination. So there's a few combinations that are trying to investigate that and see if we can get to treatment-free remission. It'll be fantastic if at least half or more of our patients could have that as a reality.
Yeah, that last one you mentioned, that's ABL-001?
That's correct,
right.
Yeah.
Okay, and actually based on, I think some of the work was done at MD Anderson and at Moffitt, SWOG is actually looking at a randomized phase 2 study where we add in ruxolitinib with dasatinib or nilotinib in patients who've achieved a CCYR but not a major molecular remission.
Yeah, that's true, and that's because there is some good data that suggests that these leukemic stem cells, the CML stem cells, are very dependent on the JAK2, and at least in vitro, it worked well, that combination, to eradicate the disease. Both, as you mentioned, Moffitt and us did some piloting, and there's some intriguing responses. They were both small studies, so I think this study will be very valuable to give us an idea of whether that could be another way to go.
Yeah. Well, Jorge, I've kept you longer than I promised I would, so, but I've enjoyed this conversation. Thank you, Dr. Cortes, for this insightful discussion. And thank you to our audience for watching this targeted oncology presentation on precision medicine.